Consider the following scenario. Mrs. Jones, a 75-year-old lady, presents to the emergency department for an acute health problem. She is assessed, receives treatment, and is asked to follow up with her regular general practitioner in a few days. There are some further issues that need addressing, but these are best undertaken by the primary care doctor. Mrs. Jones is discharged from the ED and leaves. But what happened to Mrs. Jones? Did she see her GP, and when? Hello, I'm Michael Tam, an academic GP. I'm a staff specialist of the General Practice Unit, part of Primary Community Health in Southwestern Sydney Local Health District and the Ingham Institute of Applied Medical Research and UNSW Sydney. I'm a senior lecturer in the discipline of General Practice, University of Sydney. It's my pleasure to talk about the ED to GP study presented at GP17, the annual scientific conference of the Royal Australian College of General Practitioners. This study was a collaboration between the General Practice Unit and the Fairfield Hospital Emergency Department. Belinda Watson, a medical student researcher, was the study lead, and I had the honour of being her research supervisor. The ED team included Belinda Pelazon, the ED Nursing Unit Manager, Lucy Band, the ED Deputy Director, and Harry Doan, the Director of Medical Services. Kudos must go to Belinda, who managed to conduct this study along with her full-time medical studies as a fifth-year medical student. We thank and acknowledge GP Synergy, who provided medical student scholarships for GP research. Belinda was one of their scholars. This study was published in a paper in the July 2017 issue of Australian Family Physician. A copy of the paper can be accessed from tinycc/ED2GP. Patients like Mrs. Jones are presenting at increasingly common rates to Australian emergency departments. As is well known, the Australian population is ageing. Older persons are the fastest growing group presenting to EDs, with a growth rate of 6% per annum identified in previous research. What is not well known are the GP follow-up behaviours of older people after an ED presentation. The aim of this study was to explore this topic. How many older people, and who, attended follow-up with their GP? Our primary outcome was the proportion who had attended GP follow-up by day 7 after discharge from ED. We explored whether a number of factors, including demographic factors, mobility, and social isolation, were associated with follow-up. Inclusion criteria: participants were patients aged 65 years or older, presenting to the Fairfield Hospital ED during the recruitment weeks, were directly discharged back into the community, that is, were not admitted as an inpatient to Fairfield Hospital or transferred to another public health facility, and the discharge communication included explicit GP follow-up instructions. This study was naturalistic. We did not instruct the ED staff to change their usual practice, for instance, to advise patients to see their GP as a matter of routine. Patients were advised that the study was taking place through posters and a handout, but were not recruited during their ED visit. Days 8 to 14 after their ED discharge, patients who fit the inclusion criteria were contacted by phone for an interview. Data were collected through a structured questionnaire and from their ED visit medical records. The participants. From 70 eligible patients, 50 consented to participate. 60% were women. The mean age was 75 years. About 3/4 of the participants were married. In this group of participants, all participants who were not married were widowed. 58% of the participants spoke a language other than English at home. English was the single most commonly spoken language, followed by Assyrian, Italian, Arabic, and Spanish in that order of frequency. Most participants were given an Australian triage scale of 3 or 4. On average, they resided about 5 kilometres from the ED and 4 kilometres from their regular GP. About half used a mobility aid. 1/5 were rated as socially isolated on the 6-item Lubin Social Network Scale. The primary outcome. 3/4 of participants had attended GP follow-up by day 7 after discharge. The median follow-up was day 3. Interestingly, 18% of those who had attended follow-up saw a GP who was not the addressee of the discharge summary. We undertook some exploratory analyses to see whether there were any associations with GP follow-up. It should be emphasized that these results should be considered as hypothesis generating only and not definitive. women appeared less likely than men to follow up, 2/3 compared to 90%. Those who had lost their spouse were less likely to follow up. Similarly, those who did not drive a car. Taken together, it seemed that older women as a group might have barriers to follow up. Of the group that did not follow up, they tended to take more regular medications. They also had an ED admission that was on average an hour longer. A worrying possibility is that those who are less well might be at increased risk of not attending follow-up. Lastly, although the Lubin Social Network Scale score, a validated measure of social isolation, was not associated with follow-up, one of the items was strongly correlated with follow-up. This was the question, how many relatives do you feel close to such that you can call on them for help? Those who did not attend follow-up had fewer relatives. In summary, most older people did follow up by day 7. Barriers to follow-up might include issues surrounding transport, especially older women, greater illness, and lack of family supports. The results demonstrate the importance of discharge summaries and communication being available at the time of discharge. The median patient had attended follow-up by day 3 after discharge, and 6% in this study saw their GP on the day of discharge. However, with almost a fifth of patients attending a GP who was not the addressee, the method by which this communication is undertaken needs to be considered. Previous research has identified that as few as a quarter of printed discharge letters given to older people reach their GP. Secure electronic messaging and fax are more effective, but this would not have worked for a fifth of the patients in this study. Likely, multiple methods will need to be used. Uploading discharge letters into the National My Health Record might be the long-term solution. There appears to be barriers to follow-up. Further research, especially with a focus on vulnerable groups, will be needed to design interventions that may smooth the transition of care between EDs and GPs. Where next? In 2018, a follow-up study, ED to GP for women, will be conducted. Specifically, we will be exploring the intentions of GP follow-up, actual follow-up, and perceived facilitators and barriers to follow-up for older women. We are also potentially replicating this study at another site, one with a population very different to Fairfield. Thank you. Please read our paper in AFP at tinycc/ED2GP for the full details. I can be best contacted by email at the University of Sydney, michael.tam@sydney.edu.au.